Hi, Mike Gibson coming to you live from TCT 2024, and we're having a roundtable discussion about vulnerable plaque, past, present, and future. We have some real experts in the field talk about the past, the people who came up with the concept in 1989. Jim Muller, Peter Stone are on the line to talk about this. Let's fast forward now 35 years later to TCT 2024 this year. Confirmed two results presented here. Let's look at the whole chain of the progress of this field. We're going to start by talking about the original vulnerable plaque concept, again, originated by Dr. Muller, who'll go through that. Then we'll talk about, yes, we have the images, the static pictures, but then there's the structural or functional part of it, rather, with shear stress. Peter Stone's going to walk us through some of the groundbreaking work he's been doing, looking at that. We'll then talk about a new staging system for coronary artery disease and the importance of early screening. I'm one of those people. I had a calcium score, just got a calcium scan, 1100. And then that directed me to understand that even though I was on atorvastatin and ezetimibe, I still had an elevated Lp(a) that was very, very high, and it changed my therapy. So screening can change therapy, and we'll talk about that. Then how do we put the concept of vulnerable plaque into action clinically? And at that point, we're going to hear from Udo Hoffman and Jim Lim about that concept. Finally, we'll talk about the progress, the amazing AI progress that's being made, superimposed on angiography. Again, figuring out not just based upon the structure, but also the flow elements in these arteries, moving beyond just the constituents to also flow, really doing world-class definition of what's the vulnerable plaque now, 35 years later in 2024. So let's start with you, Jim. Let's go back in time to 1989 when you and Peter and Toffler introduced the concept of the vulnerable plaque.
Thank you, Mike. It was a while ago, and I'm happy to say that the instruments to find it are getting steadily better, both non-invasive and invasive. So Peter and I were working on circadian variation, heart attacks more frequent in the morning. And then we studied triggers, and we were discussing why is it you can play tennis one week, not have a heart attack, and play tennis the next week and have a heart attack. We thought the plaques must change. So we decided to call them vulnerable plaques. At the time, I was working against nuclear weapons, and someone claimed the ones in North Dakota were vulnerable to the Russians. So that word was on my mind at the time, but we came up with that concept at the time. And we described a vulnerable plaque as one that is likely to rupture and thrombose. We didn't say it was a TICFA or a erosion site or a calcified nodule. It was not histologic, it was conceptual. But then over the decades, the methods to find different types of histology have vastly improved, which makes the field so exciting right now.
Jim, it's interesting. You know, we often talk about risk factors. Those seem to be the chronic things, but then there are triggers, which are, you know, things that are happening in the environment. It's a complicated thing. Those are two very separate issues.
Yeah, we used to call them acute risk factors. The tennis game, the tough argument, waking up in the morning. These are risk factors for an event. They don't determine it, but it can happen. One of the problems with the field, of course, we've got tremendous drugs. I'm on Repatha myself, Mike.
Me too.
And so I'm down at 30. But then I look
I'm 27, Jim. I got you beat. I'm at 27.
But I look at this curve. I should feel happy, but I don't, because this is the evolocumab results, and there is a reduction here of 15%. But what about the 85% of events that still occur? That would be flat. That's what cardiology's goal should be, and it's not. So maybe the vulnerable plaque finding can help flatten that curve out. And then, of course, you ask, why would you have a heart attack if you've got an LDL of 30? Well, you may have developed over decades a plaque like this one shown right here in an autopsy specimen with cholesterol crystals. And yes, cholesterol might have started it, but lowering the cholesterol might not reverse it. So it might well require interventional therapy. And that's, of course, a very exciting question that's being studied now. Now, in terms of imaging that plaque, that I showed you histology, here's a different way to image it with OCT and near infrared. This was done in an autopsy specimen. So here is a thick-capped fibroatheroma. And then here is something that looks a little more scary on OCT. And the histology that goes with that is a thin-cap fibroatheroma. So what's so amazing about this is that this near infrared plus OCT imaging, you get the picture, you get the chemistry with the yellow spot. It has the potential to find the thin cap fibroatheromas in living patients. And of course, CT making progress. Now, over the decades since the concept was introduced, there was a lot of controversy. And many people said you can't find vulnerable plaques. You know, it's a systemic disease. You don't know where it's going to strike. But over the decades, there have been multiple, 8 or 9 long-term studies in which people image something and then wait for events. The most amazing one is the one from Uchida at the top with angioscopy done in the 90s before statins. If he found a white plaque, which was probably fibrotic, there was no trouble at that site. If he found a glistening yellow plaque, which was most likely a TICFA, it was an 80% event rate. Now, things have improved, and statins bring down that 80% event rate. But we have Prospect 1, where ultrasound imaging found vulnerable plaque. We have the Viva MACE SPIVA study, same results. Clima MACE, same results. Prospect 2, not shown here, had the same results. All the reported studies where you measure something by IVUS or OCT or NIRS and think that it's going to cause more events at that site, all of them are positive. So that's led to the next question. No one wants to go to the cath lab to find if they've got a vulnerable plaque. So is there a good screening method? Here's a slide I've been showing for quite a while from Clearly that shows that artificial intelligence can be used to interpret angiograms obtained without a catheter in the artery and find plaque composition. So this to me is very, very exciting because it gives life to Dr. Braunwald's algorithm that, you know, Peter and I both worked with Dr. Braunwald for decades. So it's amazing to see how much foresight he had here in 06. He said, screen people, and we can add more genetic and proteomic screening. If they are at risk, have a CTA. If you find a high plaque risk, a high risk from CTA, they could go to the cath lab before the first coronary event. And if they're found to have a very high risk from invasive imaging, then they might get local treatment. So there's lots of excitement about this algorithm for managing patients. You know, we're all very happy with low event rates in patients on treatment, but there are hundreds of thousands of sudden deaths in the US alone in people that are not on any therapy. So we hope that that can come to life. And with that, I'd like to turn it over to Peter. I've had the joy of working with Peter for many decades, and I have to say, he's taught me about shear stress, and I think it's partly anatomy and partly local hemodynamic conditions that create these horrible events. Peter.
Jim, thank you very much. And it's a pleasure to be part of this roundtable. It's very exciting. And I think A lot of information has happened, and it'll be great to go over those and see how we put it all together. I'd like to just put on the table this slide to start with, which gives us a bit of a sense of the spectrum of plaques that we see. On the far left here, you can see the kind of stable angina plaque. This is a coronary artery of the right coronary artery that is representative for any patient who has coronary artery disease. And we see this tight plaque. This would be representative of what that plaque would look like histologically. It was one of those white plaques with calcium and a rock pile that certainly causes ischemia and a positive stress test and angina and high calcium score, but it doesn't kill us. And in sharp contrast, we have these areas throughout the rest of the coronary artery that look sort of ratty looking, luminal irregularities, and these are represented with the plaque on the right, where the lumens preserve because of outward remodeling, but we have a gigantic plaque that is just poised to rupture and lead to this terrible event as shown here. And our task nowadays is to figure out what is it that takes plaques like this, if we can identify them, and what leads to that one. And I think what's a very important aspect for us to be aware of is that we've had many years now of identifying the anatomic characteristics of the plaque, but we've learned recently in the past decade or so how inadequate that is to identify the plaques that will destabilize and cause a new event. For example, in the PROSPECT study, the large plaque burden, which is the most powerful prognosticator, less than 4% of them were associated with a new adverse event. TICFA, thin cap fibroatheroma histology, is thought to be so important. Less than 5% of those were associated with a new clinical event. So it's become clear more recently that identification of the simple anatomic substrate, which is necessary but not sufficient, is indeed not sufficient to predict the individual plaque that will progress and destabilize. And so we must also identify other local pathobiologic stimuli that are responsible for that plaque to destabilize and lead to a new event. And of the various things that are happening to plaques inside our bodies is how blood is flowing across each plaque. This is an example of the blood flow across a particular area of endothelium. And the endothelial shear stress or wall shear stress is the force of flow across those individual cells. And you'll see on the right upper panel that it is a minuscule amount of physical force in the range of 0 to 10 pascals, minuscule compared to tensile stress or compressive stress, but it uniquely works purely by physiologic signaling. And so a minuscule signal can lead to gigantic anatomic events. This is an illustration of the patterns of shear stress of the blood flowing across a coronary artery endothelial area. And this is just one example of a case that a patient from one of our studies had luminal irregularities only, but when we measured it, it was low shear stress in this immediate area. And lo and behold, this patient went 8 months later in developing an acute MI because this area here, this large plaque that was surrounded by low shear stress, ruptured and caused the problem that led to the acute MI. And lastly, the addition of these biomechanical shear stress patterns to the anatomic parameters begins to illustrate the idea that if we use combinations of plaque anatomy that's high risk and hemodynamic areas that are high risk, we can achieve far greater prediction than either alone. This is from the same anatomic parameters that Jim showed a few minutes ago from the prospect study, showing that a TICFA with a small minimal luminal area and a large plaque burden is predictive, but only 18% predictive. And if we take those exact same parameters, same exact plaques, and simply compute the shear stress environment within which each plaque is located, if we add the anatomy and the low shear stress, we can triple the predictive accuracy of that particular plaque to cause trouble and perhaps put up consideration for a preemptive PCI to prevent that plaque from playing out its adverse outcomes. And so in summary, the intravascular imaging, IVUS, OCT, and NIRS has demonstrated clearly that focal areas of plaque destabilization and MACE can indeed be identified using CFD metrics around a plaque as well as the anatomic constituents. But this is not really feasible for a large number of patients who have atherosclerotic disease and are unaware of it because there may not be flow-limiting disease and no symptoms, but yet they still have it. And there are applications using these same exact principles as Jim illustrated a few minutes ago, that we can look at some of the CCTA characteristics of both the lumen and the artery wall and compute CFD as well, the computational fluid dynamics, and we will be able to risk stratify both the substrate for trouble, that being in the anatomy, and then the superimposed additional stimuli of the flow patterns leading to important and very valuable risk stratification using the CCTA alone. And it may well be, to put on the table, that we can start with the idea of this non-invasive imaging. Broad populations can be done multiple times over time, if necessary, to identify a patient who is at risk for coronary disease or has coronary disease and no symptoms. And then if it looks scary enough, we can then consider invasive catheterization for higher resolution, perhaps, enhanced resolution for risk assessment, and even consideration of preemptive PCI at the same setting. So I think we are coming along dramatically from where we had been multiple years ago, back in 1989 when we identified the risk, now to better characterizing it, to have a risk basis of each individual plaque.
Peter, that was spectacular. You know, when you think of something rupturing, you think of, say, high shear stress. So it's a little counterintuitive that it is low shear stress from a mechanical perspective, but it is that low shear stress area, that's where you're getting all the inflammation. Is that the link?
That is absolutely yes. And I think it's interesting, and this is getting into some of the details, but they're important details, is that the only thing in the lumen is the shape of the plaque. And the shape of the plaque is going to have a peak, which is the minimal luminal area, as in that cartoon, but that peak will have an upslope and a downslope like every mountain. And of course, the idea of the volcano is what gave Volcano Company the name. That's what was thought to be the plaque, but in fact, it's far more complicated. And if we consider the high peak and a sharp slope, that gradient between the sharp slope, the peak, and the bottom of that slope, that gradient is probably the most predictive of all metrics because it incorporates both the high shear stress and the immediately adjacent low shear stress. And as you point out, that's where all the inflammation is located.
Peter, I'll never forget when I was at the Brigham with you, when we were doing our regression studies, this was really highlighted by a pair of identical twins. One of them was a psychiatrist, had a screening stress test, then had a widowmaker osteal LAD lesion. He said to his brother, you know, you better get in and have this looked at. Had exactly the same lesion, an osteal LAD lesion. So it points out that it's more than just systemic risk factors, there's also anatomic risk factors, right?
Absolutely, absolutely. And we're just getting the tools to be able to identify those that are both the constituents of the plaque, either done invasively before or non-invasively, as Jim showed a few minutes ago. And then if we supplement that in a critical way with the forces acting on that anatomic substrate, I think we're really getting to the point of identifying the individual plaque that's at risk, regardless of symptoms, just in the person's body.
Great, Peter, thanks so much. We're now going to hear from Jim Min and Udo Hoffman. Talk to us about all the advances we're making now with CT and how we can do all this non-invasively.
Thank you, Mike. And Jim and Peter, I mean, tremendous work, congratulations. You two are really some of the founding fathers of vulnerable plaque research and insights. I'm gonna start actually from a very different perspective, and that is the epidemiology perspective and patient perspective. And I hope that at the end, in the discussion, we can meet in the middle and find a solution altogether. But this is the reality, that despite all the progress that we have certainly seen over the last 30 years, whether it's in technology or whether it's in medical therapies, that cardiovascular disease still remains the #1 cause of death, 40% more than all cancers combined. And it is to remain the primary cause of death over the next decade. So when you look at that, it's really an epidemic. Cardiovascular death occurs every 1.7 seconds. Women actually have 3 times more cardiovascular deaths than breast cancer. And the tragic aspect here is that the average of a fatal heart attack is 50 years, a 50-year-old patient. When I worked with the Framingham Heart Studies for many years, one of their key publications in 1974 was to show that 50% of patients die from a heart attack without prior symptoms. And this is a study from a contemporary claims data database in 5 million patients who survived a myocardial infarction. And despite that this is 50 years later, we still see the same number. Cardiovascular disease, coronary disease is a silent killer, with more than 50% of patients suffering from an MI who have had no prior symptoms and did not even know they had coronary disease. So even if symptom-based care would be ideal and identify everybody who potentially would have a heart attack, we still would miss 50% of the patients completely. The second thing is we don't know who is at risk. Most patients suffer from MI, have normal cholesterol, and about a third have no cardiovascular disease. You guys mentioned LDL previously, but it is probably relatively unknown that when you look at the population-based studies, MESA, Framingham, LDL cholesterol at baseline is not related to events. What is related to events is the change in LDL cholesterol after therapy. That is very much established. But I think what this slide shows that the value of what we call risk factor evaluation is very limited to precisely predict who is going to suffer from an MI. And perhaps because of the two first points here, what we see in our healthcare system today is insufficient prevention, with more than 2/3 of heart attack victims not being treated with preventive medical therapy at the time of an MI. So there's much work to do. And how can we be better? And so, one way is, we didn't have to look far, because when you look at cancer prevention has been transformed over the last 30 years by instead relying on symptoms, physical exams, or very simple methods to a direct imaging of the disease with advanced methods such as mammography, colonoscopy, and lung CT scan. And based on these images, there are systemic and local treatments that are given to the patient based on a staging system for disease. Whereas today's heart care is still limping behind maybe 40 years. So we still relying on risk factors. We still wait until symptoms occur. And even then, we most often perform stress testing, which again does not image the disease, but rather sequelae of the disease. So in heart care, systemic and local treatment is based on risk factors, symptoms, and sequelae. Now, we do have a tool. I did my first coronary CTA in 1992 in Germany on a patient with a Siemens machine, an EBCT prototype. And so we have come a long way over the last more than 30 years. And what we believe is that can we change or shift and elevate MI prevention to the level of cancer prevention by shifting from treating risk factors to treating coronary disease? Peter has shown some images and Jim has shown some images. Coronary CT is now a standard method. It's the only non-invasive method for direct visualization of coronary heart disease, atherosclerotic plaque, and stenosis. The best scanners can do a whole heart scan with less than 1 second, with a dose less than 5 millisievert. We can determine the presence and extent of plaque and stenosis. And after several randomized trials like the Scott Hart trial, the PROMISE trial, and others, we have now level 1A recommendation in the guidelines. We're looking for reasons why have not been so successful. Now, when you look at symptomatic patients, the primary testing method of choice for many, many years has been functional or stress testing. This is a head-to-head comparison in the PROMISE trial, where patients were randomized into anatomic testing on the left side, that was coronary CTA, or functional testing that included primarily stress perfusion imaging, nuclear stress perfusion imaging on the right side. And so you see here the Kaplan-Meier curves for a normal test, mild abnormalities, moderate abnormalities, and severe abnormalities. You can see that on the hazard ratios that the accuracy, the prognostic accuracy of CT is much higher, and that especially a normal versus a mildly abnormal functional test has no discriminatory value. When you further look into the data, then you see a mirror of discordance, and that is that the majority of MACE in patients who underwent stress testing occurred in patients with a normal stress test. And when you think about it, that's not surprising. These patients might have had coronary disease, but no warning signs, no symptoms, no warning signs, not only for the doctor, but also not for the patient's own heart, so they couldn't develop collaterals, and most likely died from or had an MI from a sudden rupture of a lesion. When you look at the CT, though, the majority of major adverse events occurred in patients with non-obstructive CAD. Now, this is not new. These are data from the CONFIRM registry, but they are predicated by data from pioneers like Ambrose, Valentin Fuster, and others who have shown that when a patient is imaged within 12 months before an MI occurs, the majority, in this case in the CONFIRM registry, 75% of patients have less than 50% stenosis. So again, a pointer that stenosis does not equal risk for MI, but that the risks are in patients in plaque and in the plaque composition and in the hemodynamics, as Mike as Peter and James described. And so, what is a potential solution? So you look here, this is risk incidence rate of MACE by year. And the blue bar you can see here in the middle is ACVD risk score. And this is specifically a population that we're focusing on. Those are patients with increased risk, either with diabetes, pre-diabetes, or metabolic syndrome. About 80% of them have an ACVD risk score between 20 and 25%. So from a risk basis, they look like the same. And so it's very hard to treat them differentially. However, when you would put them in a CT and you would look at presence of stenosis and plaque, extended presence of stenosis and plaque, and you would stage the disease based on that, you can differentiate subpopulation with very, very different risk. So you would see people without CAD that have a very low risk, and then you would have people with stage 3, which is a lot of disease, who have a risk that is by far worse than secondary prevention patients. And you could think further that based on this insight, you would be able to treat these patients very differently, based on a CAD staging. And, I think that is a very promising approach that we hope we can show over the next years that it works.
Well, let's turn things over to Jim Min now. Jim, some comments from you?
Thank you very much, Mike. We've heard from several of the leaders in the field a number of different topics, and I guess it's my exercise to try to see how we can integrate them all together. And so from Jim Muller, what we heard about were triggers to evoking an acute coronary event, and then how that research led to better understanding those lesions that would be culprit to that event. We further learned through Peter Stone that it's not just the phenotypic anatomic appearance of a lesion, but it's also the local physiologic processes that surround that lesion. And then through all of that evolution, we've heard from Udo that we can now transition from a lot of these autopsy-based histology studies past the invasive studies that can't scale to large scales of groups of people to a completely non-invasive approach that allows us to better study all of these lessons learned, but without the tools to be able to generalize them to clinical practice. So, I mean, the things that I've heard from you guys today is that we talked about the risk factors. Jim, you put up a slide, people on PCSK9 inhibitors showing a 13% relative risk reduction and an 87% residual risk. I think that we now have safe tools to be able to find those patients who are at residual risk. So what I take from all of this, and please guys correct me if you think that my conclusions are wrong, but the focus of this entire discussion, all three of you, was the focus on disease, not surrogates of disease, and to be able to track that disease over time. I think we understand the vascular biology. We've got safe, non-invasive tools to be able to do it. And I think now we've got an armamentarium of tools in our toolbox to treat this disease. What we do fairly poorly is identify those who are at risk, as Udo Hoffman pointed out. We do, I think, a fairly poor implementation of trying to standardize the identification and treatment of those folks. And then finally, I think we are now learning that there's a dynamism to this disease that we need to be able to track the plaque over time to see its changes. If we could do all of that, guys, do you think that we can then eradicate this problem, namely measure disease, not its surrogate, understand and integrate the vascular biology concepts, improve our identification to everybody at risk, implement the therapies well, and then continue tracking over time to identify those with residual risk who represent the majority of the patients that we treat.
And it comes back to, yes, we're treating people systemically, but should we be treating those vulnerable lesions focally or locally. There was an interesting article this week that said 6 weeks of pre-PCI, PCSK9 inhibitors. I want to call it now pre-PCISK9, adding the I into the PCSK9 word, delipidated or reduced the plaque volume, the vulnerable plaque volume, the non-calcified plaque volume by 40%. So, we may be able to use systemic therapies more aggressively to modify things locally. But this has been a beautiful exercise in showing, how we can now, we have the tools to identify these local areas. I published a paper quite a while back looking at STEMI patients and where the lesions are relative to the distance down the artery. Arteries are branching structures, just like trees. It was exactly where you would predict from the Fibonacci cascade of the branching point. It matched up perfectly. So we know these lesions are often pretty proximal that cause the MIs that are clinically manifest and important. So is it time with some kind of strategy? We're not quite there yet with bioresorbable stents. People walk into my office every week with new technologies to try and treat things locally to preserve artery function. Jim, where are we with focal treatment?
So it's at an exciting stage. As many probably know, the mostly a Korean-led group randomized patients with non-stenotic plaques that looked vulnerable by any one of 4 measures, invasive measures. And to the surprise of some, they showed a benefit of stenting those plaques. The study was too small to have MI and death as the only outcome. It included repeat PCI, for which it's criticized. But still, it was quite interesting. And then at the Vulnerable Plaque meeting in Spain, the annual meeting 3 weeks ago, Peter Stone and I just saw the patients that got the benefit from stenting of vulnerable plaques. And I always put in a question mark, how were they imaged? The ones that got the benefit, it was confined to the group that had a vulnerable plaque defined by near-infrared spectroscopy. So they're going to show that again at TCT in greater detail in 2 weeks. But there's a lot of problems interpreting OCT images. There are massive problems in interpreting virtual histology, which was an unvalidated early method. And the plaque burden by IVUS to find vulnerable plaques is flawed because there are lots of big plaques, maybe half of them, that are collagen rich and not lipid rich. So all these measures that we've had over the decades, they're getting steadily better. They're getting steadily more accurate at vulnerable plaque detection. But I would add one more thought, and this goes to Jim Min and Udo. I think what the marvelous work that you're doing with CTs, with AI interpretation of the CT angiograms, there's a big development that could relatively suddenly occur if it is proven in the cath lab that those plaques can be treated quite effectively with some kind of focal intervention. The stented arm in the Korean trial has no events coming from vulnerable plaques that were stented. So you trade a high-risk vulnerable plaque for a modern stent complication rate, which is quite low. You've got a pretty good deal. And then you've got people throughout the world who don't have coronary disease, might have risk factors. They're going to wonder, do I have a plaque that needs invasive treatment? So that's, I think, ahead within the next 5 to 10 years.
Yeah, they may not have systemic risk factors, but they may have an anatomic risk factor that they don't understand. Let me ask Jim and Udo this question. We talk about predicting MI, but are these MIs ST elevation MIs with plaque rupture, or are they plaque erosion MIs with non-ST elevation MIs? What do we know about that, and how good is CT at predicting non-ST elevation MI or plaque erosion?
Jim, I leave you the
Okay, I'm happy to take that. So that's a great question, Mike. I'll answer it in a couple of ways. I think that the largest study ever to look at the natural history of patients undergoing non-invasive CT imaging and followed for incident acute coronary syndrome. So not, a gestalt of MACE, but true acute coronary syndromes. Didn't look at that. They looked at just the incidence of yes, no, did they have an MI? And they did not differentiate whether it was non-STEMI or STEMI. They further did not differentiate whether it was plaque rupture or plaque erosion. As we know, temporally, over the last decade, we've seen steering towards plaque erosion over plaque rupture. And that hypothetically is due to a lot of the natural history of the medical therapy that we've given to our patients. What we have learned on CT is a couple of things. One, it's particularly good at ruling out folks who present with non-STEMI who may not have an adverse prognosis, and can be used to differentiate these small troponin leaks versus patients who have significant burden that should go to the lab. I think the other thing that we've learned, which is maybe not as scientific and rooted in vascular biological concepts that Jim and Peter have taught us, but the lipid-rich plaques on CT that correlate to near-field infrared spectroscopy correlate to about 98%. It's good to identify lipid-rich plaques. And those plaques on CT are very dark. Turns out they get very dark black. It also turns out that the flip side of it, these calcified plaques that are very highly dense, are somewhat associated, they're somehow associated with the lower rate of incident acute coronary syndromes. But what we see in CT is that it is a continuum, namely that the darker the plaque, the more dangerous it is, and the brighter the plaque, the safer it is. So there isn't a fibrous, fibrofatty, fatty, calcified categorical ordinal measure. It really does seem like a continuous phenomenon. That actually helps you in clinical practice, right? Because if you treat somebody with a really dark plaque, as long as it's getting brighter over time, you know that you're going in the right direction. Whereas if it stays really dark, you know that you're not. I mean, that to me is where CT can offer assistance in that whole identification, treatment guidance, residual risk identification issue. We used to always tell the folks when I practiced at New York Presbyterian Hospital that there are two goals here, not one. The first goal is that if you come in with 100 units of plaque, we're going to try to keep you at 100 units of plaque. We're going to try to stop the formation of new disease. But number two, amongst the 100 units of plaque that exist, we're going to try to turn all the dark plaques bright and stabilize that transformation of plaque. I think when I hear patients who are very attentive to their cardiovascular health, they always talk about their numbers. Their numbers, when they talk about it, are LDL or ApoB or particle number or particle size, all these things that have been associated in large groups of people with atherogenic potential and incident events. The problem is that while coronary disease is an LDL-mediated phenomenon, it's not a serum LDL-mediated phenomenon. So I think you really, in order to understand risk, you've got to go to the plaque level, not to the blood level. So the numbers that patients should be talking about is, what is my plaque volume, right? Like, how much do I have? And specifically, how much of the dark plaque that I have? That's what we heard from Alex Van Roosendaal today at TCT. Right, that 3,500 patient 5-year outcome study called CONFIRM-2, I think was the first global registry really to demonstrate that when you adjust statistically for everything, two things remain as predictors: non-calcified dark plaques and severe stenoses. And calcified plaques don't predict anything at all once you adjust for the bad actor, which is the non-calcified plaque. Why is that the case? I think the non-calcified plaques, it's because of all the things that Jim and Peter taught us. And I think the stenosis severity is because once you get to a narrow MLA, the thrombogenic potential to occlude the artery becomes much higher than if you have a large MLA. So I think it makes sense with everything we learned 35 years ago from Jim and Peter, and we're coming full circle in a non-invasive way today. You know, many people don't know, but Peter and we have an NIHR1 that we've been working on for a number of years, where I think CT also adds not only its non-invasiveness and its ability to be able to generalize to large numbers of patients, it's also 3D, right? So think about all of those images that you saw that Jim and Peter presented. We see them always at the vulnerable plaque meetings. They're always 2D cross sections, but the topology of a plaque matters, right? So what you're talking about in terms of the gradient from the peak of that plaque to the plateau of that plaque, I mean, even then it's not a straight line. There's a topology to it. I think we're going to use this 3D imaging to really better learn what's going on in the local environment.
I just want to go back 30 some years ago. I was sitting in a room with 27 films, cine films, that no one knew how to analyze. And my mentor, Peter Stone, was very encouraging. And I literally had to look at the films under a microscope, literally, that then got it into a DEC computer. And we looked at shear stress. And it was areas of low shear stress that was related to the most rapid disease progression. And then, of course, I invented the frame count where we can now calculate velocity down arteries. And you start putting velocity and QCA and shear and everything together. It's been an amazing 35-year journey to see how all this has played out. And now as a patient, I was fine. And then I got a screening CT. I got a screening calcium score, 1100, and it changed, my therapy. It got me onto the right course, knowing that my LP(a) was 300, knowing that I had to get all my risk factors down. So I've lost weight. My LDL is 27. I do think these kinds of screening tools will make a tremendous difference. They have in my life. I'm just so honored to be here with the people who really developed this concept, Jim, Peter, and the people who are moving it forward with Udo and Jim. Thanks so much for joining us tonight, coming to you live here from TCT 2024.